Doctor, over to you.
Thank you. Hello, good afternoon, doctors, and welcome to this experience sharing program on managing PPH, managed by Hitro. Hitro Healthcare, as you know, doctors, we have got 25 years of excellence with 36 state-of-art manufacturing facilities. We have got 300 plus products in our portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARVs, APIs, and FDFs in the world. Hitro Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovations, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic area, Hitro Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to their patients. Because of which, in August 2020, Hitro received an award of Pharma Excellence for COVID drugs. Today, in this experience sharing program on managing PPH, we have got Honorable Speaker Dr. Ritika Agarwal with us. Madam, welcome. Dr. Ritika Agarwal is Associate Professor, Venkateshwara Institute of Medical Science, Gacharula. Madam is MBBS Fellowship in Reproductive Medicine, Mumbai, FAMAS, DMAS, and Diploma in USG Jefferson University. Madam is Vice President Moradabad Obstetric and Gynecological Society, gynecological and obstetrician, over 11 years of teaching experience, and keen interest in IVF, infertility, diagnostic laparoscopic procedures, ultrasound, obstetrics, and infertility. With this brief introduction, I hand over the session to Dr. Ritika Agarwal. Welcome, madam. Over to you.
Thank you, sir. Thank you for the kind introduction. I would like to thank Hetero Healthcare as well for giving me this opportunity to discuss a very vast topic about postpartum hemorrhage. So, overview of the postpartum hemorrhage. What is postpartum hemorrhage? Any blood loss that is happening after any delivery of more than 500 ml in vaginal and 1000 ml in cesarean section is termed as postpartum hemorrhage. Postpartum hemorrhage are common and can occur in any woman who is at risk or at non-risk. PPH is leading cause of maternal mortality in low-income countries like ours. Primary cause of nearly 1/4 of all the deaths that are happening globally is due to PPH. Postpartum hemorrhage, it causes maternal mortality. Around 35% of all the deaths in the female is happening because of postpartum hemorrhage. In developing countries, 240 per 1 lakh live births, as compared to developed countries where only 16 deaths are happening. So we are trying to get down to that ratio by 2030. Global PPH incidences, 14 million women suffer from PPH. That is, incidence is around 2% to 4% in vaginal delivery and 6% in cesarean section. So this ratio is more not because cesarean section are causing PPH, but because cesarean section mostly are happening to the cases who are high risk. Because of that, this ratio is high. Then PPH incidences in India, 38% of maternal deaths are happening due to PPH. 25.7% of global deaths are taking place in India, and 2/3 of these are attributed to PPH. India has an unexceptionally high rate of maternal deaths, that is 540 to 1 lakh per live birth. So what causes PPH? The 4 T's that is the cause of PPH. First is stone. Anything that is causing uterus not to contract can cause PPH. Then is thrombin. Any coagulopathy that is happening in the blood of the patient, maybe it is anemia, patient has low hemoglobin, or thrombocytopenia, patient has less platelet, or bleeding time and clotting time is disturbed. Then trauma, anything that causes any trauma to the uterus. So maybe in cesarean section, extension of the uterus, extension of the scar could happen, or in normal delivery, cervical tear could happen, vaginal lacerations could happen, or in instrumental deliveries, again, extension could happen, or tissue, any retained product. So in normal delivery or in cesarean section, either the blood clot has removed, is still there inside the uterus, or second thing, placenta could be there inside the uterus. So how will we classify that somebody has PPH? So abdominal tenderness could be there. Patient suddenly, a happy patient, a normal patient will have collapse. So BP, blood pressure will go down, or the pulse will become increased. Abdominal gut, if she has bleeding inside the abdomen, so abdominal girth will start increasing. Uterus, normally after delivery, uterus contracts rapidly, but suddenly if there's a loss of uterine tone, then it could be maternal tachycardia or vaginal bleeding could be there. If she's having a lot of hemorrhage, so we can see the blood. So there are classifications of blood loss. So from compensatory phase till mild, moderate, and severe. So if only 500 ml blood is lost, so 10 to 15% blood loss is there. Patient will not have any symptom change in the blood pressure or pulse rate. She'll just have a little palpitation. She'll become a little dizzy. She'll have a little weakness. Then in cases of mild PPH, blood loss has increased. It is more than 1000 to 150 1500 ml. So it is around 15 to 25% of the total blood has been lost. So because of that, if suddenly so much blood has lost, blood pressure will fall down. So blood pressure from normal range will come down to 80 to 100 mm of Hg. Then if that much blood has been lost, she'll have weakness, she'll have sweating, and again tachycardia will continue. In moderate, it is more than 1500 to 2000 ml of blood loss. So again, the pallor will start occurring, and in severe blood loss, suddenly collapse will happen in the patient. So the BP has gone down from 50 to 70, and air hunger will start occurring, and she'll have no urine will be there, so anuria will happen. Can we have the next slide, please? So how will we diagnose? So initial evaluation, every patient, the normal assessment has to be done. If the patient becomes, patient has tachycardia or hypertension, or then we will assess all the vital signs and the amount of blood loss. During examination, what is when the blood loss is happening, we have to examine the laceration or hematomas are there, manual examination for any retained product, placental tissues there, or in if we have bedside ultrasound available, we can do the ultrasound. And uterine tone has to be checked. For laboratory, we have to send all the hematocrits, hemoglobin, platelets, and all the coagulation profile has to be done. So if the patient has had PPH, what can we do? So as I've already told that first thing is tone. So if she has poor tone from abdominal palpation, we have to see if we can see the fundus. If we cannot see the fundus, just palpate the uterus. If the tone is there or not, if it is not there, then first of all, send the full blood count, send the coagulation profile and electrolytes. If the urea could also be sent. If we have a bedside ultrasound, ultrasound could be done. For management, what we can do is oxytocin already uterotonics have to be given. So oxytocin have already been given. Then next thing is prostaglandin or ergometrins that could be done. That could be done for hemoglobin algorithms. See whatever things could be done. If she requires surgical management, we can shift the patient back to OT. If she can be managed by medical management, it could be done. We can also do uterine massages. That is also helpful. If in cases of tears and traumas, then again, if the bleeding is there, rupture is there, you have to shift the patient to OT. Again, the genital lacerations are there, you can stitches outside during normal delivery. Blood has to be sent, blood reports have to be sent for this also, ultrasound is available. If you can see a laceration outside, you don't need an ultrasound for that. Management, as soon as you identify, you have to go for the management. For the retained tissue, again, you have to, if it was a normal delivery, try to remove the placenta itself. If it is not possible, then you shift the patient to OT, give GA and remove the placenta there. In cases of coagulopathies, give replenishment. If she has low hemoglobin, you can give him blood. If she has low platelet, you can give jumbo packs. And till the time those things are coming, you can just give colloids to improve the blood volume. So rationale for development of carbetocin, why was it required? See, we are maintaining cold chain when we get the drug, but the drug is not being given to us. It has to deliver. So the factory is maintaining the cold chain and we are maintaining the cold chain. The in between things, the cold chain where it has to be maintained, sometimes the ice is not there, the light is not there. In India, the temperature rises a lot. So because of that, oxytocin and ergot alkaloids should be kept refrigerated all the time. Otherwise, they degenerate. Then heat stable oxytocin is not available anywhere. Previous formulation of carbetocin, they had to be stored between 2 to 8 degrees. And resource poor countries do not always have a cold chain, that I've already told. So the need of carbetocin, its shelf life is 24 months. It at 30-degree temperature with 75% humidity. The the need of cold chain is not there and is provided in vials. So one person, you don't have to calculate the doses. Just take out one entire vial and inject it. So utrotonics, the use, when can it be given? So first of all, what all molecules are available? Oxytocin is there, carbetocin is there, ergometrin is there. Sign ergometrin is you using both of them combined. So ergometrin plus 5 units of oxytocin is used and mesoprostol. These are all the drugs that are available. What time can we give? So first is crowning of the head, you can give it. Then sometimes in the delivery of the anterior shoulder, or in second stage of labor or delivery of the placenta. Prophylactically, when can they be used? For to prevent PPH or at the management of third stage of labor, and therapeutic just to maintain to manage PPH. So carbetocin, the next generation to manage PPH. So first of all, see, when you see the molecular structure is mostly the same apart from just the NH2. That is where the stabilization and the prolonged half-life comes. So carbetocin was created by, it is a synthetic long-acting analog. So the entire molecule is same except for just the two parts that have been changed. So it becomes a long-acting to prevent postpartum hemorrhages, and only one vial have 100 micrograms of carbetocin in 1 ml of solution. So it reduces enzymatic degeneration of the product. So how these two things are different, oxytocin and carbetocin. So synthetic cyclic peptide from naturally occurring posterior pituitary hormone is oxytocin. It binds to oxytocin receptors and in uterine myometrium, and it stimulates the contraction of the uterine smooth muscle. Similarly, carbetocin is a long acting, but it is a synthetic analog of oxytocin, which has agonistic properties. So carbetocin also binds to the oxytocin receptors, but it causes rhythmic contraction and it increases the frequency of existing contractions. This is the reason we cannot use carbetocin for induction of labor. Then kinetics, oxytocin could be used as an IV, and its peak contraction occurs after 30 minutes. This could use carbetocin can be used as IV, but the peak contractions start between 2 minutes and last up to 6 minutes, and rhythmical contractions can occur till 60 minutes. Storage and transport, oxytocin has to be transported between 2 to 8 degrees, and it has to be stored between 2 to 8 degrees Celsius, and in carbetocin it can work till 30 degrees. Again, I've already told you, for induction we can use oxytocin, for augmentation we can use oxytocin, for prevention of PPH and for treatment of PPH. Carbetocin can only be used for prevention of PPH. Can I have the next slide, please?
Can you hear me, madam?
Yeah, but the slides are not moving.
This one you wanted?
No, I've already this one. Yeah,
Yeah, this one.
the next one, sir. This one I've already talked about. Yeah.
Okay.
So these are few of the okay. So this is a champions trial that was done by WHO. In this, they had the efficacy compared between carbetocin and oxytocin. More than 30,000 patients were included in this trial. So first of all, the blood loss of more than 500 ml was seen. Okay. So in carbetocin group, 14.5% and oxytocin 14.4%. 0.1% is very less, but when you're doing it in a larger group of patients, even 0.1% makes a lot of difference. Then in blood loss more than 1,000 ml, 1.51%, and in oxytocin 1.45%. In safety profile, at least one unanticipated abruption happened in cases of 4.9%, and in oxytocin it was 4.7%. The frequency of expected AEs did not differ significantly between the two groups. So in conclusion, the carbetocin was not inferior to oxytocin for the prevention of blood loss of at least 500 ml of blood, or the use of additional neutrotonics were not required. Even in the same thing, in the Cochrane review, 11 studies were compared involving 235 women that were included. It also concluded that carbetocin is associated with less blood loss compared to the cyanometrin in prevention of PPH for women who have vaginal deliveries in association with significantly fewer adverse effects. So guidelines, we have a lot of guidelines. WHO, FIGO, German, Australia, and France has their own separate guidelines. Only one of the guidelines for prophylaxis of PPH, only one of the following has to be used. So mostly the WHO says oxytocin, misoprostol, ergometrin, everything. The Canadian SOX says only carbetocin. The New Zealand one says active management of third stage of labor for a prophylactic uterotonic could be used. FIGO says carbetocin. Germany, Australia, and Swiss body says carbetocin, and France FEGOX also says carbetocin.
Madam, thank you, madam. You have been using carbetocin since how long, madam?
I think it came in India around 2.5 years back. I've been using it
Yeah,
for
yeah,
past
yeah.
2 years.
Okay, this has been your first slide.
Yeah.
Okay. Now, this case studies, madam, you suggested these 3 case studies.
Okay. So these are my own personal case studies. All three of them, I've just taken 3 cases. These three are the cesarean sections that I had done. First case was 37-year-old female. She was gravida for para 2 living 2. Two of the cesareans were not done in a very good facility, so we were expecting them to have adhesions and blood losses. For this patient, her hemoglobin persistently has been 9. So we started doing the cases along with the a blood in hand, but that we didn't require. As soon as the baby was delivered, as soon as I delivered the head of the baby, I'd given a carbetocin intramuscularly for this patient. So uterus contracted, though it was a very flabby uterus, and but we didn't require anything else. Just the massage and a carbetocin was given. The second case was 28-year-old female. She was gravidously para 2 living 2 with twin pregnancy with PIH. So again, two of the high risk factors were there. She was grand multipara with twin pregnancy with hypertension. So I was expecting that she might have PPH. So prophylactically for her also, as soon as the second baby was delivered, before delivering the placenta, I'd given her carbetocin, and again second dose was not required for her also. She didn't land up in, it was a good delivery, and she didn't land up in PPH herself. The third case was 32 years old female with the gravida 2 para 1 living 0. Her first pregnancy also ended up with a cesarean section abruption, and she didn't get the baby. In When she came to us, she was not a book case. When she came to us that time also, she had abruption, she had thrombocytopenia. Her platelet was somewhere between 78,000. For her, we had to repeat carbetocin. So one carbetocin was given immediately after the delivery of the baby. And when I started suturing, after removing the placenta, the uterus became flabby. So after 15 minutes, I had to repeat one more carbetocin for her. Both the all 3 cases, only IM carbetocins were used, and no other uterotonics were given, and they didn't land up with proper hard PPH. In the third case, I had to give blood, just not because of the PPH, just because she had already had abruption and thrombocytopenia. So prophylactically, one blood has been given to her.
Some of the questions, madam. Madam, what I've seen is that in all 3 cases, you have used intramuscular carbetocin.
Yeah.
Do you normally prefer intramuscular, or sometimes you use intravenous routes also?
I have not required intravenous route till now
Okay,
because in our setup we don't take very high risk patients. So
okay,
maybe if somebody with very low hemoglobin and thrombocytopenia comes, we might use intravenous also.
okay. Of course, the advantage of intramuscular is a longer duration of action as
Yes,
compared to intravenous. Yes, it may take
definitely.
slightly longer time to
The
act, but then
longest
the
time
duration of
to
it, yes,
start, but it goes on for a
yeah,
very long time.
correct, correct, which may be necessary in some of the settings.
Yes.
What is the patient profile where we can expect PPH? I mean, we can
Any
expect in any
patient,
patient. Yes,
yeah, any patient
yes.
can have PPH, but if we know the high risk that is hypertension, twin pregnancies,
Hmm,
previous chances of PPH or
correct.
thrombocytopenias, and those there it is more chances of PPH is there.
Even more so in fibroids or patients with
Yes.
high blood sugar, they are also
Yeah.
likely to get. Madam, does the position of placenta make patients more predisposed to PPH?
Yes, anterior placenta, which in the previous scar also causes
Yeah.
PPH, or placenta previas are more likely to have PPH,
Okay.
or the
Okay.
placenta, deformed placenta, big placenta, or accentuate lobes, they also have PPH.
Yes.
just give me 1 second. हेलो
Yes. Yes.
बेटा मैं मीटिंग में हूँ थोड़ी देर बाद फोन करना yes sir.
Yes. In which of the patients would you prefer to use carbetocin or oxytocin for prevention of PPH? Any specific cases that you feel that you should use carbetocin straight?
Yes. So again, if placental abnormalities are there, as I've told, the four T's for
Correct.
PPH. So
Huh.
in those four T's, anything if you are expecting that tone will not be there. So
Huh.
like in twin pregnancies, in as you said, diabetes
Fibroids.
mellitus.
Yes.
So who
Yes.
have polyhydramnios. So anything that causes loss of tone, or in which we already know that the thrombocytopenias or any other placenta abnormalities are there, hemoglobin anemic patient, we can directly give carbetocin rather than oxytocin. One more thing, if oxytocin has been used for induction, so sometimes
That's
it does
one more
not
question.
work.
Yes.
Yes, so we can
Yes.
directly give carbetocin in those patients.
In fact, you'll be surprised. The next question is the same. Anyway, can we use placenta in case of retained placenta?
Yes, you can
After,
give
of course, yes.
not right now. Once you take the patient to OT and
Yeah,
remove
yeah,
the
yeah,
placenta
yeah,
after
yeah, yeah,
that,
yeah.
not
Only,
if you are not
only
doing
after MRP.
anything.
Yes, only after MRP.
Yes.
Yes. And in case of RH negative mothers, there'll be quite many, I suppose, RH negative mothers. Can
Yeah.
we use carbetocin in your own experience, madam?
We give carbetocin, but again, I am carbetocin I can use. I will not suggest to use IV carbetocin for these patients.
Correct, correct, correct. I would is what you would suggest.
Yeah.
Because RH negative could be a big thing, especially in the interiors in our country, because if a
Yes.
lady bleeds heavily, there may not be exact blood to match to. Yeah.
And then sometimes, actually, what happens? The blood injections are being filled by the staff, and sometimes anesthetist does not
Yeah.
even read what
Yeah.
is being read. So carbetocin is a very safer drug for Rh negative pregnancies that way.
Okay. Yeah, yeah, yeah. I think methargine, I suppose, general people avoid, I suppose, in
Yes,
RH
methogen should
negative.
not be given to Rh
Yes.
negative pregnancy or
RH.
hypertensive or cardiac
Hypertensive.
patients.
Yes. Now, this is the same question which you answered again.
Yeah.
Can we use the carbetocin for prevention? Possibly because the receptors are same and then oxytocin is
They're
already
already
blocked those
saturated,
receptors.
so
Yes,
sometimes it
yes,
does
yes.
not work.
The carbetocin may not work there.
No,
Correct.
yeah. Carbetocin will work, but oxytocin might not work. So
Yeah,
if
yeah,
we
yeah.
have
After.
used for induction, then because oxytocin has been given for a very long time in primary
Hmm.
patients, sometimes the delivery takes more than 8 hours. So if
Correct.
the saturation for oxytocin has been done for 8 hours, it is nice chook for the receptors to get another drug with the same molecule but a little enzymatic difference.
Correct. And in which cases would you prefer? Of course, this will be a more theoretical question. You already answered IV route over IM route.
In
Patients with
which you
cesarean
want
section.
yeah, if you want
Yeah.
a little quicker onset of action and you're
Hmm.
not actually targeting for a prolonged time, so that time you can use IV route.
Carbetocin. Yeah. Immediate answer. If the patient is not responding adequately with carbetocin, there will be sometimes these patients. What additional uterotonics you would use in your order of preference? Huh?
See, I have not used it, but prostaglandins could be used
Yeah,
or misoprostol could be used,
yeah.
or we can go for surgical management if bleeding or things if
Of
nothing
course,
is
yes,
happening.
yes. I mean, the last resort is, of course,
Yeah,
uterine
surgical.
artery blockage. Yes, because once PPH occurs, the whole hospital is there at the site.
Yes,
It's an
and
emergency.
you have to
Yes,
be very quick. You don't have to
absolutely.
be prophylactically doing this. That
No, no,
eventually
no, no.
later on I'll do whatever best possible things you have. Just give
Absolutely.
everything.
Yeah.
First
Because
30 minutes in PPH is very important.
yes, yes, because life is at stake finally.
Yes.
And what are the advantage of a carbetocin over other uterotonics?
See, one thing that I felt in my setup once carbetocin is there, and like we have 3, 4 cesarean sections, the staff doesn't have to run back again and again to the refrigerator to take out the fresh vial.
Correct,
So
correct,
they can just
correct.
take out all the three together. Second thing is, I'm very sure that the cold chain has been maintained. The cold chain does
Yeah,
not have to be maintained. So
correct.
I'm
Worried.
not bothered about the
Yeah,
disintegration of the molecule in these
correct,
patients.
correct.
And
Yes,
second thing is they can give it to mostly every patient rather than just questioning about the blood group of the patient or the parameters of the patient. It could be safely given to everyone. So my mind is not there. I'm totally confined to the cesarean rather
yes,
than bothering about the injections there.
correct. And the single dose use and the
Single
intramuscular
dose
use
uses,
further adds to
yes.
this. Yes,
And secondly,
further adds.
IV and IM both can be used. So if somebody by
Exactly.
mistake gives one thing in one patient IM, one patient IV, they're not scared about that also.
Yeah, correct. And in the interiors, we may not get those IV setups and paramedical staff, to for all this, doctor
Correct.
using straight. This would be
And in
that hard.
oxytocin, one major problem that we were facing was if a new staff came, they were rushing the patient, and sometimes pulmonary edema was happening. That is one
Arre
very
Bap.
major drawback of oxytocin drips.
Okay. Huh. Madam, have you experienced ADH related side effects anytime with oxytocin?
No, not personally.
Okay. Because some people say, that if you use it for longer period of time, then maybe the ADH gets activated and all
See,
those.
I've read about it, but in my
Yes.
setup, we have not experienced it.
Yeah, correct. Should carbetocin be kept as a reserve drug or it should be used as a first line?
See, if you're working in a low resource setup, it should be your first line of drug.
First line. Correct. And especially if you're anticipating PPH, especially in those PPH prone
For
patients, you should
anyone
use it
now,
again.
though, we have totally shifted to carbetocin. Matlab mostly, I'm using oxytocin only when my carbetocin is finished and the
Absolutely.
next slot is
Yet
going
to
to
come.
come in after a day or two.
Correct. Yeah. What is the role of an anesthetist, vis-a-vis gynecologist in choosing a drug for prevention of PPH?
I don't think so. Anesthetist. And say again depends on how which setup you're working. In our
Setup,
setup
yes.
we already talk about everything before
Ah,
starting the surgery, that if
okay.
PPH happens you have to follow certain things, you have to give this. So my anesthetist work according to what we have,
Okay.
what role we have planned for him.
And basically, anesthetists will follow gynecologist guidelines and
Yes, whatever
instructions as they
guidelines have
follow.
been
Yes.
pre-decided, and it is better to talk to an anesthetist or a pediatrician before you're
Absolutely.
starting the
Absolutely.
surgery.
Yes, yes. So that they are also on the same page, and so they
Correct.
know that. And anyway, IV line is always there. If anesthetists can
Yes.
easily. Yes. And to conclude, what is your overall experience using carbetocin? Importantly, a take-home message for the audience. Take-home message.
Yeah, so one major take home message is main thing is to prevent PPH. So if you have carbetocin, well and good. If you don't have carbetocin, don't ask the person to go out and get carbetocin for you. Whatever drugs you have to prevent that PPH. Second thing is don't be very overconfident. PPH can happen to anyone at any time. That primees don't
Absolutely.
have PPH or normal deliveries don't have PPH. Anyone with good BP with good hemoglobin can also have PPH. Second thing is carbetocin, because it is white. The only problem carbetocin is facing is it's a new molecule, and the old doctors or the veterans of our institute who are in medical who are in who've been keeping updates are using it, but the old timers they don't want to change. I'm telling you about my own mother. She's a
Yeah,
gynecologist. She has
yeah.
not shifted to carbetocin. I've
And that's
told
not
her
a
so
text.
many times. She does not. I'm very happy with my pitocin. I will not change that thing.
And madam,
So
that's our textbook brand. Now we have read it in our textbooks.
Yes.
Yeah,
So
very
till
good.
the time you change the molecule and make everyone aware. It's a very new.
Right,
It's not
right.
a new thing now. It's like a two. It's 2 years
Yes.
old thing,
So
and everyone is
relatively new
marketing
then.
it so well. And the prices come
Relatively
down
new.
drastically. Initially,
Yes,
so it
yes,
was
yes.
quite expensive.
Madam, thank you so much. Thanks for your insights. Well, although though I got so much of experience about using carbetocin, Indian doctors, our own doctors' experience is very important. And thank you very much for this, especially intramuscular use. I am sure the doctors must have benefited out of it because there are many doctors who use IV, and someone using intramuscular. I mean, it gives them more of confidence. Thank you so much. Thanks for your time on Sunday afternoon. Thank you so
Thank
much.
you, sir.
Thanks
Thank
all
you for
the
having
yes.
me.
Yeah. Thanks all the doctors who have taken. But there's one question which has come:
Yeah.
advantage of carbetocin or prostaglandin?
Over prostaglandin.
Yeah.
Okay, so carbetocin has rhythmic contractions. So, and prostaglandin, what it does is it is contracting the upper segment and the lower segment together. So sometimes you don't want that, like in cases of very thin lower segments, or in cases of retained placenta where the pits are, you want the things to go out. So where the rhythmic contraction is there, contraction is happening and relaxation is happening. So that is always safer. And second thing is if the patient has hypertension and suddenly the contraction happens, so suddenly the blood can shoot up. So that is one more
Hmm.
advantage that carbetocin is giving over prostaglandins.
So the alternative relaxation is very important in terms of
Yes.
safety. Right? That's right. Thanks, madam. Thanks once again. Thanks all the doctors who took time and attended this session for your interaction. Thanks marketing team Hitro for organizing, sales team for super coordination, and IT team for your IT support. Thank you all of you. I wish you a very good evening and signing off for Hitro. Thank you, madam. You can sign off, madam.